Again, grand rounds this morning. Next month in September, we have a special guest. Dr. Mavroutis is also going to give grand rounds. It's a special lecture, so that'll be the last and final voice lecture. So I hope you can make it next month. So what we're going to do today, there's going to be a number of speakers. I hope, I guess, if they show up. Dr. Shah is going to start off with changing outcomes of cardiogenic shock. Thank you.
All right. Thank you, everyone, for making the time to come early in the morning. It's certainly great to see all our cath lab people here. It's a different grand rounds than we normally do. Usually we have one speaker. Today we actually have 3 different service lines. So we're coming together to present a case and work our way through the process of how we came to formulate a shock program and hopefully make it successful. So Dr. O'Brien here is from the emergency department. He's the medical director. Dr. Silvestry is the surgical director for the thoracic transplant program, and they'll both be involved in today's presentation. I don't have any disclosures. Dr. O'Brien, speaking for him, has none, and Dr. Silvestry has none pertinent to this presentation. So I'm going to give you a little bit of outline what we're going to discuss today. We'll start with a case presentation. It's always a good place to sort of engage the group. We'll work through how the emergency room sort of approaches this problem. We'll talk about the chaos of shock and then how the devil is in our data in terms of how we came up with what we needed to do. We'll do a little bit of algebra this morning. And then putting it all together, we'll put our shock team formation and talk about relational coordination. We'll talk about mechanical circulatory devices and sort of the concept of best effort, best care. And then we'll have Dr. Silvestry at the end kind of present his data, his slides, and closing remarks. So Dr. O'Brien.
Hi, I'm Blake O'Brien. I'm medical director of the emergency department in Orlando. It's an honor to be together with you guys today and kind of show how we want to get a multidisciplinary group together to attack this challenge. And you'll see from this case, it really highlights some of the complexity, and sometimes you can get lost in some of these patients. And if you can find the pathway early, the patients will do much better. So, like most case presentations, it starts out pretty nebulous. It was a 35-year-old. He comes in with general complaints, mostly general weakness, lower extremity edema, and cough. So it's kind of vague symptoms. He's fairly young, and he doesn't have much of a medical history, probably not much prior medical care. He has a social history of some alcoholism. His vital signs is he's tachycardic with a heart rate of 150. He's an AFib. He's hypotensive, 92/75. So you know right away the guy's in a little bit of trouble. But it's important to see the initial blood work, and you see you've got a complex issue in front of you. His white count's not very high. His heme concentrated. His hemoglobin's elevated. He's thrombocytopenic. He's got signs already of acute liver failure, which is not good at all. His INR is elevated, and his liver enzymes are elevated, and he's in acute renal failure with slightly elevated potassium. And then this is kind of the current state or the historical state of kind of what happens when you have a mixed picture of shock. And you see this quote in the chart on the admission. It says he's been transferred to our ICU for closer observation and management of his acute liver failure, kidney failure, hypertension, hypoperfusion, shock, sepsis, metabolic acidosis, and acute CHF. So we're kind of lost from the beginning here, and it's going to take some smart guys to kind of figure this out and turn it around. So you remember, shock has a common pathway, as you see with that patient. It's just pretty much a state of hypoperfusion and organ damage that's reflected in some of the lab work. And this guy was already pretty far along when we had evaluated him. And pretty much the kings of shock that we see in this institution are hypovolemic shock. The hemorrhagic ones usually see in trauma centers. Then this distributive shock, which is what I deal with mostly every day, is the septic shock. But cardiogenic shock is a special, distinctive type of shock that we're going to differentiate today, and it's what these guys are experts in treating. And we'll kind of just go through how to differentiate that. And the faster that I get out of the way in the emergency room and get this figured out quickly, and I get them involved, you'll see that patient outcomes are much different. So just a quick background, anytime we have cardiac output is just heart rate and stroke volume. So if you impact either of those, you have a problem. And it's an easy way to think about cardiogenic shock because it's central to the heart. There's the acute myocardial infarctions, about 7% of those will actually present in cardiogenic shock. Myocarditis is one of the famous ones, and that can have more of an indolent course and can be difficult to diagnose. And can have kind of an onset like this guy had of a 2 to 3 week illness. And then there's obstructive shock, which is different. I just put it here because you'll see in some of the evaluation that we can do, you can actually pick up on some of these quickly and not make the wrong diagnosis. And then there's mechanical issues within the heart, acute mitral regurg, and some other valvular abnormalities. And then there's your arrhythmias that create cardiogenic shock just because the heart's not pumping correctly. So we've all known with all types of shock, when you have a low state of perfusion, lactate's always been able to predict mortality. And that's been studied since the 70s, and it really is our kind of current state that we look at as for survivability and how sick the patient really is and how low their perfusion state is. And it's very important background for these patients. So since I was in residency, we've been doing a lot of work with end-tidal CO2 and how it mirrors lactate. And I'd like to use a lot more in this institution. Where I came from, we used it really as a second-to-second monitor of perfusion. It's a continuous lab that you can get even in non-intubated patients. And it's a really great indicator of perfusion, even with CPR. The real importance of this slide is just to show there's an inverse relationship between the lactate and the end-tidal CO2, and it's been studied ad nauseum now, and it's an accepted marker for whole body perfusion. And it'd be really interesting as we move forward with this program to see how end-tidal CO2 can interact with cardiogenic shock patients. So in an emergency department, you want to be able to walk into the room with the shock patient and actually walk out of that room having a great idea of the underlying etiology of shock. And we don't want to end up with the statement that we had at the beginning of this case. So now when we walk in the room, we actually have a lot of data coming with us. If the patient had been in any part of our system, I can rapidly see that at bedside. We bring the computers into the room. I can see if they've had any recent cardiac information in the computer. And I think that has to continue because we can get that information very quickly and relay that on to the consultants as fast as we can. And a lot of these patients, shock kind of looks the same when you evaluate them. The only difference in cardiogenic shock is you can see some obstructive phenomenon, some JVD, some peripheral edema like this patient had, some signs of volume overload. In acute cardiogenic shock, sometimes those haven't come into play yet, so it can be a mixed picture. And there are a lot of types of shock that can overlap. So you look for a lot of physical exam findings, and a lot of times, it's kind of nebulous. And the EKG is really helpful here. You'll see from this program as we start out, we're really focused on ST-elevated MIs leading to cardiogenic shock. If we can get at that population, the rest of the more difficult myocarditis and other etiologies, I think we can explore. But we're going to go after the STEMIs, and those will reflect on the EKG. So that's an immediate help when you see somebody that has a mixed picture of cardiogenic shock, has an abnormal ischemic EKG. You already are on the right pathway. We have bedside lactate. It comes back very fast. So we'll immediately know what the perfusion status of the patient is. And then I can immediately hook someone up to end-tidal CO2 and see how they're perfusing second to second. Anything less than 25 mirrors a symptom of poor perfusion. Chest X-ray, obviously in decompensated heart failure, it really helps you. In some of these acute cardiogenic shock, you may not see a lot of volume overload. A lot of times you'll see pulmonary edema. But remember, certain types of septic shock can cause ARDS and a similar chest X-ray findings. So the big deal for us then is how can you differentiate the type of shock? With all these non-specific findings, what's really the thing that's going to tip your hat and allow you to engage the cardiologist and cardiothoracic surgeon if they're needed? And we've been able to get more proficient in ultrasound usage in the emergency department. We have a really nice machine. I bring it right into the bedside. And this is your big differentiator. In almost every other type of shock, the heart is really doing a lot of work. It's a hyperdynamic heart. If you see it, it's really cool. It squeezes really fast and really hard, and it's trying to perfuse. Because in other states of shock, you have, you know, vasodilation and other problems that are causing the shock, and it's not the heart. In cardiogenic shock, the heart is really struggling to beat, and you can notice that very easily on an echo. The other neat thing is we can do IVC compression pretty easily where it crosses through the liver, and you can compress it in a hypovolemic state. It's easily compressible, and in signs of cardiogenic shock, you can see signs of volume overload or euvolemia, where the IVC is either normal or it's difficult to compress. So if you put all that information together, you go into a room, you have a person that looks shocky, that's not perfusing, that's hypotensive, that has elevated lactate, decreased in tidal CO2, and then has an echo that really doesn't show a heart that's functioning well. The goal here, as you'll see today from the other speakers, is to get to mobilize the cardiogenic shock team so that a lot of things can be deployed rapidly for these patients and decrease the mortality. So I'll let Raj talk about what happened with this patient.
All right. So just to continue on, you know, we got him through the emergency room, and this patient was actually at one of our outlying hospitals here. And at midnight, you know, the patient came in around 1700, and all those derangements that you saw were at around, you know, early evening hours. At midnight, you know, the patient becomes hypotensive even more. The lactate's up, patient's on a pressor. Patient's still in AFib RVR, the creatinine's still 4, is coagulopathic, he's got transaminitis, LFTs are still elevated. It really wasn't until the next day, at around 1 o'clock or so, by the time the cardiology consult was actually done and seen, and, you know, at the time the echo was done, and noticed that, voila, EF is 5 to 10%. And it wasn't at that time until I just got almost a casual phone call and said, hey, listen, I got this patient that's kind of looking like this, and it happens commonly. And I'm like, we're in a whole lot of hurt here. Let's bring the patient down immediately. There was no Swan-Ganz catheter. There was no measurement of hemodynamics at that time. So we actually, the first thing that we did was just put a Swan in the patient, and we can actually clearly demonstrate that, you know, there's basically biventricular failure. You know, the RA mean was 36. The PA pressure was not that high, suggestive of the RV was failing. You know, the wedge was 35, and the patient was, you know, struggling. So the diagnosis for this patient, if you're just going to put it in sort of one line, was severe decompensated biventricular congestive heart failure. And, you know, if you've been doing this long enough with that level of derangement that we have with this patient, the decision was made and almost pre-planned that we were likely going to put an ECMO on this patient because he needed to be supported with such multi-severe organ dysfunction. Over the next 15 days, he went from being intubated to extubated in about 3 days. We actually did put an IMPELLA in to try to help wean off the ECMO too as well. There was a short-term amount of you know, CRT that we did for about 3 days, and the renal function actually normalized. The EF actually went from, you know, being what it was, 5-10% to about 30-35%. Ultimately, at the time of discharge, closer to 45%. He was off the inotropes and pressors, and actually the right heart pressure is actually normalized. ECMO was removed about 5 days after insertion, and, you know, many times when we remove the ECMO, we actually have our vascular surgery colleagues participate in terms of that removal, just to help make sure that the vascular repair part of it goes well. The IMPELLA was removed, and essentially, you know, without saying, is that, you know, patient's coagulopathy, transaminitis, renal failure was all resolved. Patient went back into normal sinus rhythm and ultimately improvement in EF and was subsequently discharged. And, you know, it's one of our very good saves. This kid was 35 years old. And, you know, when we do these cases, you don't know the whole story, but his mother had actually just died 2 months prior to that of some kind of cardiomyopathy. And his dad was like, you know, I've tried to help my son. He's had alcohol use. He drinks like 2 or 3 beers a day, you know, for the last, you know, 15 years or so. And he was really struggling to try to help his son. At the same time, you know, he's kind of get over his wife's death, and now his son is on the brink of death. And, you know, it's there's nothing greater than an opportunity to save life, and I think that we had done a very good job here, although slow, but we did it. The incidence of cardiogenic shock is slowly but steadily increasing. You know, the patients In many cases, are older, they're living longer, they have more coronary disease. We've done things to them already in the past. And therefore, generally, when they present many times, it's almost like, the straw that broke the camel's back. They have such level of disease, and then they present with essentially pump failure. There are many causes, as Blake actually went through. Acute myocardial infarction is just one part of it, and that's the majority of what we see. But there are other causes too. Mechanical complications, although happen infrequently, are pretty devastating. And unless you interact or engage emergently, you can actually spiral quite quickly, such as post-infarct VSD, papillary muscle rupture. Free wall rupture tends to be sort of an instantaneous death in those cases. They're very rarely actually survivable. RV infarcts, we see them a lot, actually, right? We see them in patients, and they're sick. They're really, really sick, and sometimes harder to treat than the left-sided. There are other rare causes, such as aortic stenosis, hypertrophic cardiomyopathy. Those are extraordinarily rare. But acute AI, if you've ever seen acute AI in terms of septic shock, they'll present, and then they'll blow their aortic valve. Their LVDPs are severely elevated. They're very, very, very sick. Those are the patients that we can help. We've seen that in our thrombolytic trials, the lower the blood pressure, the higher mortality, okay? It's intuitive, but actually the trials actually show that. And it's partly because of the cycle of chaos, okay? There are two sides to this, right? There's a systolic and diastolic phase to this. The systolic phase is everything goes down, right? The pump goes down, there's hypotension, hyperperfusion, decreased coronary perfusion leading to ischemia. The diastolic portion of this means that the LVDP goes high, the lungs get flooded, there's hypoxemia, and leads to further ischemia. There's inflammatory markers that are also sort of amplify this already sort of spiraling cascade. And if we don't act early in this stage up here and we wait down here, it's hard to recover those patients. Tissue perfusion ultimately leads to the patient's multi-system organ dysfunction. And in these populations, you're talking about 50, 60, 70% death. I mean, that's big. Okay? So, here we go. All right? The devil's in our details, okay? It's in our own data, all right? So, I will show you, this slide is actually going to show it a couple of times in this presentation, but I just want you to focus on this side of the curve here. So, when we sort of embarked on this journey of trying to figure out where our mortality is coming from in our own program. Mind you, when you do a PCI at our institution and the patient dies from almost any cause, it counts against our program. Now, there's a lot of banter in the literature whether that actually means anything or not, but nonetheless, that's how we're being graded, okay? And so we had to go back and ask ourselves some questions and said, we think that we're doing a really good job, man. We're getting great, everything in and out, blah, 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 blah. But we're not producing in terms of mortality. Where is our mortality coming from? So this was an this was an eye-opener for us, okay? And it is what it is. This is our institution. These are the numbers that we have, and we had to kind of find solutions for that, okay? So we'll come back to this slide. So this is a very fancy version of what I did. Was one day I just sat down, I think it was Elizabeth, and we actually sort of kind of plastered out where we're struggling, okay? So this is actually a really good slide, and I think that it speaks well for our institution. We do almost 2,000 PCIs here at this institution, okay? Total number of PCIs, okay? And when you break it down into, those are in the STEMI population and everything else, okay? You come down to about 271 STEMI patients in this quarter 4, 2014 to quarter 3, 2015. If you look at it, so you have 35 total mortalities of all the PCIs that are done, but in the STEMI world, there's 21. So 21 of the 35 deaths that occur in our STEMI program, or in all the PCI program, occur within our STEMI program. And when you make your way down, we actually kind of broke it down a little bit more and said, okay, which ones are really, truly cardiac and non-cardiac? Most of them were cardiac related. So you almost have half your deaths, okay, more than half your deaths, that are related to the STEMI program. Did further deep dive. Why are they dying? Most of them, all of them actually, were in cardiogenic shock, okay? So if you're gonna die having a heart attack, you're gonna end up in cardiogenic shock, okay? And this is actually even, we went a little bit further. We tried to figure out, okay, they're in cardiogenic shock. At what point are they in cardiogenic shock? The point is that they're in or near the cath lab when they are close to dying, okay? And most of them were in, 15 of them were just had been in the cath lab or in the cath lab. So it's very illustrative to us is that we do a fantastic job, actually. Think about it. We do 2,000 PCIs, and of all the complexities that you all see every day, anesthesia deals with it, surgery deals with it, interventional cardiology deals with it, we really have a very small number of deaths, and most of those deaths are occurring as a result of a complication of an acute MI or something along that pathway, and all of them are in cardiogenic shock. This is the same numbers. Actually, this is 2016 data, okay? So I kind of presented the end of 14 and 15. Actually, this is 2016 data, so it's a little bit more updated. And again, the numbers are fairly similar. If you see that those numbers, we're doing 2,000 PCIs, there's actually only 26 deaths. And if you work your way through this same pathway, there's 280 some STEMIs that we do, 14 of them were in cardiogenic shock. So 14 of the 26 deaths were in cardiogenic shock, okay? And if you work down the other pathway, which is everything else, the stable coronary disease where it has angina, or even the non-STEMIs that were in this pathway, 9, okay? So patients were dying because of cardiogenic shock, and we weren't doing as good a job. Now, all these numbers down here, okay, are devices that we were placing in patients, okay, that we really didn't get a positive outcome. So could we have done better? Yeah, absolutely. But our usage of devices was actually a little bit lower than what you would anticipate, okay? All right, so a little bit of math in the morning, okay? I'm a Michigan fan, okay, but I do have to give credit to Ohio State coach actually who had this. I actually saw this the other day, okay? It's E plus R plus L, okay? The event plus the response is our outcome, okay? The event has already occurred. The patients are dying, okay? It's happening, okay? We see it in the program. It's our response that's the only thing that can really change the outcome, okay? And so as a result of the things that we were seeing, the 100% mortality, that goes without saying, but we did deeper dives, okay? We had struggled in terms of trying to figure out what risk-adjusted means. And then the final path thing that we had actually tried to focus on is trying to find better ways to deal with cardiogenic shock, okay? All of these things play a role in our sort of overall mortality. Oh, sorry. All right, so the concept of a cardiogenic shock team is not new. Cardiogenic shock is not new, okay? But what we are doing is new to our institution, and it's a rarity. There are not many institutions who put that much effort behind this type of endeavor, but because we are a quaternary center, we're not our parents' hospital anymore. We are a new hospital, bringing in patients from all over the country in the Southeast, that the use of a multidisciplinary team to try to address a very complex problem, to appropriately triage patients, because most times patients don't need anything. They maybe need cold cool. They don't need to be in the cath lab. Sometimes it's really, truly hospice or palliative care. And in rare circumstances, a patient needs to go to the lab, and we may need to do something more. There are many different sort of states of cardiogenic shock that get patients into the team. The cardiogenic shock, on this side here is probably more appropriate for our discussion, which is there are different levels of shock, and then we have to appropriately place those patients in the right pathway so that way we can actually appropriately treat them. So how do you do this? Well, first, when you come up with a team, you have to have criteria, right? You can't just say, let's just do it, okay? Now, trials in cardiogenic shock are often very small and difficult to do. The shock trial is sort of our sentinel trial because we don't have much. And it's really, the question is, should we emergently revascularize occluded coronaries in cardiogenic shock? It's a 6-year trial. There only had 300 plus patients in them, okay? And this trial is unlikely or anything similar to be done in the future. It's very difficult to do cardiogenic shock trials, as you can imagine. But there are some takeaway lessons that we can actually grow from and build our team from is that at 30 days, there's really no difference between medically treated and surgically treated patients. So you're not looking in the short term, you're actually looking for long term, because at 6 months, there was a difference between revascularization and versus medical therapy. So some form of revascularization can be beneficial for the patients. But most importantly, and I'm sorry if this clearly does not show well, but you know, the age of the patient actually matters. Generally, those who are younger tended to do better, okay? And so when we came up with our criteria for what we would want to try to sort of focus our efforts and endeavors on, we came up with sort of inclusion and exclusion criteria. So we used the age of less than 75, evidence-based data, okay? And then we also included those things that we've already discussed, which is hypotension, evidence of tissue hyperperfusion, and clinical echocardiographic evidence of mechanical dysfunction, okay? Now, exclusion criteria, septic shock, terminal illness, these are things that are sort of obvious, severe anemia, age over 75, and the quality of life issues such as dementia, things that would be problematic for a lot of people. Now, the age is something that I want everyone to sort of take with a grain of salt. There are 70-year-olds that you would never do anything for, okay? And then there are 76-year-olds where you may want to be a bit more aggressive than you would have anticipated otherwise. So if there's ever an issue with regards to sort of should we or should we not do it, don't hesitate to call, okay? This is the effort for someone's family member, someone's dad, someone's mom. A phone call never hurt anybody, okay? Yeah, at call, yeah, we all turn into sort of, you know, raging, you know, mean people at times. But at the end of the day, you're doing the right thing. Okay, so what do we need from you guys? If you identify a patient, either in an emergency room or in the floors in a CCU, and you see that you're starting to add an inotrope, the patient's not doing well, or the EF is going down, something is not going well, you know, you do have the privilege of actually just picking up the phone and calling the transfer center and say, can you please just activate the shock team? And the shock team is really an effort bridging multiple specialties to bring them together to have a conversation, basic communication, guys, basic communication, to try to help determine which way the patient is going and which is best treatment. As part of our STEMI program, we have interventional cardiologists that are very well versed in putting in catheters, okay? And it is part of our obligation and responsibility to try to help those very sick patients. The same thing, surgery feels the same way, and I'm sure critical care does as well. Watch for signs for people who are developing early shock symptoms, as I discussed. And even if you're not sure, a phone call never hurt. Okay, so I spent a lot of time doing this slide, and I came up with this, okay? It's the only thing that sort of actually, it does capture everything that I want to say, is that everyone has a skill, and everyone has their strengths, okay? And when we have used our shock program to its best, I will have to tell you, there was a post-surgical patient who had cabbage 3, 4, 5 hours early that one of the grafts went down, okay? We brought the patient emergently to the cath lab. Anesthesia came in like, you know, Superman, okay? We brought this big thing in there and all that kind of stuff. So it's me at the table, surgeon's right behind me, anesthesia's right next to him, okay? Patient's pH was 7.0. By the time we were done, we had the artery open and the pH was corrected. Maybe 15 minutes, 20 minutes, okay? And I have to tell you, that was probably one of the best experiences I've ever had in terms of having 3 service lines in one place making it happen. So in the emergency room, they'll just use the emergency room as an example. So if you have the patient, like Blake, you know, saw that patient that we described, you know, in the emergency room, and he knows the patient is struggling, okay? He activates the shock team just by calling the transfer center. We have an interventionist on the phone just for this specific reason, okay? And at the same time, simultaneously, we can get critical care and surgery involved here as well, okay? So we are no longer making decisions on islands, because I showed you data. When we did that, we weren't doing so well, okay? But now when we have 3 people online together deciding what is best therapy for someone, I'll give you a good example. 35-year-old has been coded for 45 minutes. There's a little bit of ST elevation. What are you supposed to do? In the past, we have taken that patient directly to the lab, stented an artery, and the patient ultimately did not survive. Now, we may make a decision to say, you know what, this guy was down for 45 minutes, the lactate is, you know, 20, and, you know, end-tidal CO2 is crazy high. We're going to send this patient a cold pool, okay? And when we make that decision, we make it as a group, because then we can live with the good and the bad. It's no longer the patient, the people, interventional cardiologists. Many times we felt like we were on an island by ourselves trying to figure out what is best therapy. And quite honestly, we didn't want to be accused of not doing our best. So sometimes doing your best is not to do something rather than to do the easy thing, which is intervene. There are tremendous amount of support staff that is available to us. So once we make that decision, the patient's going to the lab, let's say, then in the lab, it's a coordinated, organized chaos. It's amazing. It's cool to see, okay? People are getting better and better and better at it. The cath lab, we call it additional personnel. We got OR personnel that come in. We got anesthesia that has been there many a time. We got critical care. So we as interventionalists don't have to focus so much on the breathing aspect and correction of metabolic stuff, but we can focus on the procedure, getting access. Surgery's there. So if we ever need to escalate our therapies, you know, we can actually do it right from there. It's pretty cool, okay? So what is the purpose of mechanical circulatory support, okay? We're really trying to do three things, okay? We're trying to provide circulatory support, ventricular support, and coronary perfusion, okay? Most times, and many times, you just have to do these two things and patients will do relatively well. But there are times where we just cannot support the patient enough. The patient is persistently hypotensive. They're in that sort of spiral cascade. They cannot seem to break that cycle, okay? And in that case, we may need to sort of upsize our efforts to try to maintain better perfusion to end organs. So this is actually a very good slide. You know, we've had several patients that have been transferred outside of our institution to our institution, but almost too late, because what they do is they start adding inotrope after inotrope or pressure after pressure, and not realizing that, you know what, the patient is not going to do well. So once you know that you've added one, and now you're thinking about adding another, then that may mean that we need to perhaps intervene much earlier with some form of mechanical support potentially. And then there are several trials actually that have shown that even balloon pumps may not be enough, okay? It didn't make a difference in this particular trial with regards to the use of balloon pumps in medical therapy versus not. This is a summary slide of these mechanical circulatory support studies. There are common themes. First, they kind of range in terms of decade, you know, from 06, 03 through 2014 or so. Many of them are sort of haphazard, you know, some are sort of randomized, other ones are observational, some are record reviews. And so you can see that it's hard to get data in this world, but we do know when you're boots on the ground that you actually need some support. It's hard to show differences when you have such small numbers, okay? Dr. Silvestry will talk about one of the trials here when he gets here. But you can see that, you know, you're dealing with a milieu where the mortality is fairly high. So, you know, you're looking to save 1, 2, 3, 4 patients. It's hard to argue that you're going to save 12, 15, 30 patients, okay? These are the devices that we have, okay? Many of them that you're familiar with. Those of you who may not be familiar with, this is a balloon pump. This is the IMPELLA device. Tandem heart is another form of mechanical support, and VA ECMO that we've become increasingly familiar with, okay? Sometimes it's a graduated approach in terms of how we get there, and sometimes we just kind of go for the Hail Mary because we don't have many options, okay? They come in different French sizes, so vascular access becomes an issue, okay? And they have different hemodynamic effects depending on what you need and how we approach the problem. This is just our two pictures of, just so that everyone kind of becomes familiar, we'll be seeing this potentially on x-rays and other things like that. This is the LV, the IMPELLA, okay? This is called the IMPELLA 2.5, and it looks like a pigtail catheter. Basically, there's an inflow from the, when this catheter is put in the LV, this is where the blood is sucked in, and then literally the blood is just deposited outside into the aorta. So basically, it renders the heart not having to deal with as much. It makes the heart a bit smaller. The LVDP goes high, the wall tension goes high. The heart does not have to do as much. This picture here is one you probably don't see very often. We actually did, I think like 12, 14 cases, something like that by now. This is called the RP IMPELLA. So this is designed, actually, and just recently got, I think, FDA approval for RV failure, okay, acute RV failure. This device was the first one put in the Southeast here at Florida Hospital, okay? All right, so we're back to my slide again, okay? So we were a mess here, okay? We did a bunch of stuff down here that actually made a difference, okay? With the reviews and with better risk documentation, we actually got down to here. We've noticed a little bit of an uptake, okay? We've already done this, and we're doing this already. So the delta here is our cardiogenic shock, okay? The difference is 2, 3 patients, okay? So if you're a numbers person, okay, you're just looking at, hopefully, maybe we can turn the tide on 2, 3, 4 patients, okay? But if you're a humanist, okay, that's 1, 2, 3 dads, moms, kids, sons, daughters, okay? And I think it behooves us to try to do best. All right, so last slide here. There are challenges and there are some take-home messages, okay? We're gonna stumble, okay? We're talking about taking a big system, taking multiple different specialties, lots of players involved, and trying to make this work. And we're gonna prevail, okay? Today's our first step. Getting the message out is also a challenge, okay? This is one venue, but there'll be others with regards to trying to get a big system with plenty of players involved to try to help coalesce towards a common goal. So it's a team effort, okay? The shock team does not mean it's a device team. So just because you call and somehow we're gonna say that we're gonna put a device in there, that is not factually accurate, actually. And more often than not, okay, we end up treating those patients much more conservatively because it's an appropriate thing to do, but now we're making the decision as a collective group, okay? We don't need to say, we will not save every patient, okay? We will not. And the data suggests that, okay? So we're not gonna change that. However, each patient, I believe firmly, okay, deserves our best effort. So a phone call never hurt anybody, but it may save someone's mom, dad, son, or daughter, okay? We don't live on an island, all right? We are surrounded by immense talent, okay, to deliver best care to the best of our abilities, okay? We don't need to make decisions in isolation anymore. We felt that as interventionists when we were on call. We get the call from the ED struggling, okay? The interventional cardiologist was struggling. We were doing things that may have not made a difference. And now we can do things as a collective group to try to make the best triage or the best decision for the patient. So sort of my take-home message is that we should give our best effort for best care to save those 1, 2, 3, 4, 5 lives that we have not been able to do, okay? I do want to thank a lot of people that don't get the credit, okay? So I have a posse here that does our quality data. They're the ones that produced all that data. They put it together in a manner that makes it's our institution's data, okay? We are what we are. We have to own it. Our cath lab and our staff have been enthusiastic about putting this all together, and they make it work. It's beautiful to see. If you've not seen it, it's amazing. Jose's here. I've been through it. I know a lot of the anesthesia guys have been through it. The ECMO folks, perfusion folks, they've been down there. You see it. It's amazing to see how well people can coalesce about one goal, save life. All the nurses on the floors who have to deal with all the stuff that happens along the way. And, you know, often people don't get any credit to the environmental services people. Having been there, done that, you know, we leave a mess, okay? We leave a mess. So I ask you, all of us, okay, after we leave that mess, is to thank those who actually clean up after us, okay? The security team, you ever see those guys? They're amazing, okay? When those people from flight come, they make those elevators work, they clear a place for us, and they bring that patient. And those 2, 3, 4 minutes, you know, that we were waiting for an elevator or not making it happen, it's amazing how much they're even invigorated on the opportunity to save life. And our flight team, okay? Our flight team that brings those patients here. They deal with them when they're really sick and they have no resources. And so I do want to thank all these people. It's easy to thank us doctors and the administrators and all that kind of stuff. It's easy. That's an easy one. But these are the people that really, truly should be applauded. Okay? And now I'm going to kind of hand it over to Dr. Silvestry to take over.
Thank you. I'm actually going to go back to this slide. How many people here have been in a code? Yeah, all of you. Okay. First of all of you or your colleagues or analogs participated in the care of the 35-year-old who we saved, who went back to his family. All of you in the operating room, in the cath lab, on the floor, everyone participated in some way in that patient's care. The people who helped stabilize him, the people who helped resuscitate him, the people who helped get him home. Everyone in this room or your colleagues were part of that save, and that's a tremendous effort. And to paraphrase Al Pacino, you know, everyone who's been in the code probably thinks, if only I had a time machine where I could have 5 minutes, right? The minutes that we need are everywhere. And what Raj said about environmental services. Those of you who've dealt with a transfer center, when you say, I can't release the bed because the bed's not available, the nurses in CVICU who work really hard to get the patient to 78, environmental services who cleans the room so the room can be available so flight can be cleared to get a patient. When the patient comes hot into the operating room and Ravi Basesa gives me a dirty look because the patient's coding, he said, no one told me the patient was coding, right? They didn't tell me either. But if we had 3 minutes, the patient might not have been coding when they came here, and maybe we could have done more. And so the minutes are everywhere, and everyone on this team is important. Has everyone flown Southwest? Everyone flown Southwest? I hate the airline, but you cannot argue with its efficiency, right? Because I like to sit in the front of the plane, I'll be honest with that. And there is no real front, you just get in a line. And so, but that's why they get in and out so quickly. It's called relational coordination, right? They communicate, the door people communicate with the flight crew, communicate with the flight attendants. Everyone communicates in a focused, respectful way, and they're able to get things done. And that's why they're one of the 4 airlines left in the United States, and their market cap has gone up by 5 in the last 5 years, right? $50 billion or something like that. So let's go back to this and say, this is timeliness, right? And we've all had, as one of my nurses in the CVICU had a hot mess express, right? And sometimes late isn't better than ever because we get in and we're left with the patient. My partner, Dr. Bada, frequently calls me when he's got a disaster and the patient comes in and says, what should we do? Should we keep going or should we stop? And sometimes the most appropriate thing is to say stop, right? When the patient really comes in and they've flown for 25 minutes and they've had CPR in the helicopter for 25 minutes and there's no activity, it's a difficult decision, but that's a strength. One of the things that we hope to bring to the excellent Cardiovascular Institute here was the idea of reperfusing the body. We get so focused when we get a STEMI on opening the artery because the STEMI industry and the STEMI focus that sometimes we forget that when we're looking at a cath lab film and we see the wedding ring going up and down as we're looking at the coronary arteries, that we have to stop focusing on the artery and focus on the patient. Reperfuse the patient because we don't like this, right? This is not, the strength of the shock team is getting the message out to identify the depth and severity of the shock that the patient's in, to decide, do we do the body first or the heart first, or if we can, both at the same time, right? The people in the cath lab know, they've seen this, that their pressure is 60 and a cardiologist is trying to open an artery in the hopes that after that artery is open, the heart will pick up, right? It's kind of like running a marathon on a sprained ankle. Sometimes it's okay. We talked about acute heart failure. The whole thing is the heart gets distended and it increases the oxygen demand. And if you have an occluded artery, in this case, it makes it all worse. I won't go into that. Ventricular unloading to save the heart is important. Our whole STEMI protocol algorithm is based on getting the heart with decreased oxygen demand, decreasing the distension, supporting the heart, raising the blood pressure, etc. Raj talked about this, and I would just group this into the different categories as intra-aortic balloon pump, evidence-based. Actually, California doesn't pay for intra-aortic balloon pumps anymore in AMI shock. If you put them in, that's great, but the hospital's not going to get reimbursed for that based on the Technology Assessment Committee. Small, 5%, maybe 10%. IMPELLA comes in different sizes, but at best it's medium support. It can give you a couple of liters of flow. Many times in a relatively normal-sized patient, an IMPELLA CP, that is the one that can give you 3.5 to 4 liters, will stabilize the patient. Maybe not forever, but well. Tandem heart, which we have yet to see here in the cath lab, but will. We've seen it, but we haven't implemented it. Can give nearly full support, and ECMO can give completely full support. And the whole thing is, besides the severity, learning to differentiate biventricular failure from left-sided failure. Left-sided MI, left-sided shock. Many things we get away with are because we unload the left side, the right side hasn't been infected. You see that patient with JVD, they're blue, they have biventricular failure on the echo. Usually a left-sided intervention will not get you out of Dodge. All right, and so that goes with the breadth and severity. And so many times we're so focused on not only the artery, but the left side of the heart. We forget about the right-sided congestion, renal failure, liver shock, everything that you see, the sequelae and the duration of their shock and reanimation will often depend on how long that congestion is there. That's not forward flow, that's backward flow. And so that's the other part that helps determine survivability. Of course, we all know that the younger you are, the more likely you are to survive because you have physiologic reserves, which is why in the older patients, the 60 to 70-year-old patients who are clearly salvageable, we have to change the threshold of our intervention away from just the heart and towards the body. And that's very important. Well, you've seen ECMO. You know, I have a meme of Oprah saying, you get an ECMO, and you get an ECMO, and you get an ECMO, right? And so the bottom line is that in cases where we don't know what the heck is going on, but we have a patient in front of us where the heart isn't working, sometimes perfusion is the best answer, right, John? Perfusion can be the best answer. And I look forward to a world where Raj has replaced me and I can order ECMO, or he can say, I put the patient on support, let's figure this out, and I actually don't get that phone call, because phone calls do kill. ECMO is not a panacea. It may be a little bit of a timeout, and that's the best way to think about it. No one really benefits from being on ECMO a long time, and the reality is that it gives you a moment to reassess and then potentially intervene. We have interventions for things. Maybe it's a coronary revascularization, maybe it's a mitral valve repair, you know, maybe it's a TAVR. We had 2 patients that Dr. Accola did an amazing ECMO on, a valve and valve, and then a mitral valve patient of Tom Martin's that had recurrent prosthetic mitral stenosis was put on ECMO because he was clearly in shock. INR of 6 would have been a re-op, which Dr. Martin would have been fine to do, except they did a TAVR valve in valve for the mitral, and the patient went home, I think 12 days later or something like that, and never got an incision. Surely would have died on the table or afterwards for bleeding because of his liver. You can't fix that. But with ECMO as a pause and a reconfiguration of some of our teams together, we've decided on things that can be done, and that patient left the hospital because of it, and I've not heard of that approach being done before, and Dr. Bada is going to write up the case. So these are some of the results for ECMO, because people say we do ECMO all the time. How are our results? So the reality is that you're dealing with people who are dead. And so death is 100% death. And you can see that in this single, I'm sorry. Let's go back. Maybe I can do that. No, I guess we're done. There. So you can see that for patients with acute myocardial infarction, myocarditis, you see that the long-term survivors in this study from 2008, a little bit, 36%, so 1 in 3. Now, these are the sickest of the sick patients. This is 10 years ago when the threshold to put on ECMO was potentially a little bit higher. But the reality is that these are patients who left the hospital with long-term survival, and this is a significant improvement in this setting. We've tried to increase the threshold to not just ECMO, but to other support to support the heart so that we get more recovery. What defines the threshold to institute the shock team or mechanical circulatory support? Well, those of you who take care of patients on the floor see these patients all the time. Maybe you get a sense of them on 78 or 88 when they're sort of going down. Maybe you get a sense of their velocity. You know, I love the E plus R equals O because that is really, really important. And it was an astute respiratory therapist that we had a patient also had a graft issue that said this patient doesn't look right. 5 minutes later, they were on 100%. 5 minutes later from that, they were in the ICU. And there are your minutes, right? It was the respiratory therapist who said this isn't right, who sounded the alarm, who got the patient to the appropriate place at the appropriate time. That patient wound up on ECMO, again, had a PCI, and went home subsequent with complete heart recovery because the window, those minutes before myocardial death occurred, and with the tools we have in this hospital at that time, putting them together at the right time, help. So you have to assess what's the adequacy of hemodynamic support. The answer in 5800 isn't to go to 0.5 mics per kilo per minute of epinephrine. That is rarely the answer, and it rarely leads to survival. So those of you who see that, and residents and fellows in the room, you know, 0.5 milligrams mics per kilo per minute of epi is not a solution. It's a shrugging your shoulders and saying, I give up, okay? Which is okay in some patients, but acknowledge that that's what you're doing. You're giving up. So the degree of the medical intervention, the degree of vasopressor support, and then I challenge you to say, it's the end organ response to revascularization and or medical therapy. So, you know, this is the conundrum we have. We don't want to institute advanced therapies in people who are too well,
right? The survival is good. We don't want to institute the therapies in people who are too sick where the care is futile, and the question is getting it to the right timing. And patients at each moment are maybe on different parts of this curve, but are heading towards where they're heading towards. Dr. Arias called me when he had a patient that he didn't like how a patient was slipping. Now that patient did not wind up on support at that moment, but having the team there was perfect because that's the safety net. And he did a very good job. He did a complex PCI, patient then velocity improved. We all had a sigh of relief and we didn't do anything. And we felt really good about not doing anything. And that's the best thing, right? So our team approach is all about, it's like Southwest Airlines. It's about shared goals and visions. It's about mutual respect, frequent, useful communication. That's how you get it done. That's how you get 3 people to act like 5, not one person, 3 people to act like 1. So we have the shock team, we have the interventionalist, we have the heart failure team, we have the cardiac surgeon, the cardiologist, the ICU, catheterization, the operating room staff. And by having this communication, which I have to thank Kimberly, Sue, Bell, Dawson, something to help gel this group and force the communication and force the protocols when we started to approach this, because we really need that here because we have all the teams and they got to work together. So I'll end there and early so we have discussion and opportunity to talk about some of these things. Why don't the 2 of you come up and...
Silvestry has left the building. I think this whole the program that you guys have presented is outstanding, and it just again elucidates the multidisciplinary approach to these types of problems, which are not just single vision problems, but requires a team or requires a village to take care of them. And again, I applaud the administration as well for having the insight to put this together, as well as you guys kind of glossed over all the work that you guys have put together and done, hours, efforts, and bringing other ideas from other institutions. And I think that, again, we applaud you for that, and from this institution, thank you for that. So we do have a few minutes for questions, comments. You mentioned the ease of starting or pushing the button to create the shock team. Raj, you want to go through just a little bit? What's the first call goes out to who? Is it a group call?
Yeah, I think it's...
Just turn off the speakers. I think everyone can hear now.
Yeah. Okay, so, as complex as this place is, it's the simplicity that will make it work. And so we had decided up front that we wanted to have sort of a one press the button thing, and then everything after that was a cascade that worked on its own. So if it was you or anybody else that said that, listen, I need a little bit of help, we need to kind of activate the shock team, it's really truly calling the transfer center and just saying to the transfer center, can you just please go ahead and activate the shock team? And that's all that's really required. Now, it depends on who's on service and whatnot, and that may be information that you could give or provide. So let's say there's already an established cardiologist that you're going to be taken care of and whatnot. You get them on the phone, you're on the phone with them, and if you need critical care gets on the phone because it's 9 o'clock at night, we need to decide where we need to head with that patient. That conversation happens simultaneously, so they'll get the other folks on the line. And the whole effort is really, this is not really complicated, but it takes a little bit of effort on our part is to communicate one sort of pathway or vision of how that patient's care should evolve. Because it's easy, we talk at it from the emergency room aspect of it, but there's been other times we've got coming for you and other people along the way, and we've struggled in terms of trying to figure out, what is best therapy, but at least that conversation happens. And it's that conversation that will ultimately lead to best patient outcome and treatment. Okay? It's no longer an isolated conversation or trying to figure out, man, I'm struggling and I don't know, but if I don't intervene, I'm going to be somehow ridiculed for not intervening. This takes that away. It takes the pressure away. This is why I told all of our interventionists, when we're in the cath lab, ask for help. It's okay. If you have a colleague or anything else or anywhere else in that realm, but calling the transfer center, asking for help, is the first step. The rest we can take care of. The rest of the transfer center will get those appropriate people on the phone together and make that conversation happen.
Yeah, I think you mentioned something very important in a plug for our transfer center, which again, Ms. Bell, we appreciate all the efforts of that. It's kind of become the Amazon, if you will, of our hospital system. You can really create anything from shock beam to code gray to get an inpatient. So I think we all have to be supportive of that. And I don't know if any of the transfer center visits are here, but again, we thank you, Eric. Thank you for all the effort because it is becoming imperative.
If I ever have a problem, Margaret would be my call. So thank you.
Yeah, so and that's incredibly helpful and obviously instrumental to the success of this. Comments, questions, right there.
So, I'm really happy to all cath lab and all the other. This is, we're a team. And when you have a patient who arrives in the ED or the ICU or the cath lab, we should all be part of recognizing when this team might be helpful. Sometimes we get really focused on what we're doing. It's incredibly important for somebody to come and step and say, hey, maybe we should be doing something different. And this is about the communication and changing the group dynamics of taking care of the patient. Yes, we're trying to win with ones and twos and threes because that differentiates us in terms of our care. We want to be exceptional. But this is a team that can actually be saving tens of ones. We're struggling with being able to put the appropriate resources, and frankly, we don't have the bandwidth to boil the ocean right now. And I understand that, and I realize that creates some tension. This is about taking care of the people who show up on our door the best way to do it, and do it as a team, not as individuals. Because the team's going to do it a whole lot better than that.
And also creates consistency.
Yes.
Creates consistency.
So when you see it, recognize it, assist the team in being able to. Toyota has a quarter to pull and they assembly line and stuff. We're all part of being able to pull that forward and get additional help.
Kevin, that's a very good point that you make. Very often, very important points are made in an off-the-cuff fashion, but consistency, I know that you strive to do that every day in your practice, and the reality is it doesn't matter whether it's Rajesh Shah, myself, whether it's Ralph, whether it's Don Bada, whether it's whomever. The focus is assess the patient, then reassess the patient, to define the shock, and then define the intervention, and then reassess. And that's the most important part about a shock team, because it's not about ECMO. It's not about that. It's agreeing to come together from different perspectives. No one's going to say how you should practice, but simply say that we should assess the patient for shock and decide what tools should be placed on that patient at that time across the board, no matter who's on STEMI call, no matter who's on interventional call, no matter who's on cardiac surgical call. And you've called me about people that you got called about for cardiac surgery, regular cardiac surgery. You're like, no, this is shock. This should be treated shock first. And that's the whole, no matter what door you come in, the approach should be standardized, because when we do that, we can see what works, we can see what tools we need, and we can do that very well. And everyone in this room has a role in this. I know I get called from the cath lab all the time, say, would you please wander down here if you're here? Because, and it makes it standard, and that's really important, consistency.
We're at the end of our hour, guys. Thank you, and not only for the. Okay, well,
No, sir.
I know when you said transfer center, today we came to this seminar presentation. We understand what the transfer center is for the cardiac. I'm not sure everybody understands that. Sometimes I don't know what's the main coming from some other place here. What is that? So I need to get that, and also I think rapid response is really involved in the hospital. I wish you guys get that in hospital.
Yeah.
Because they involve everything.
RRT, the rapid response team.
So they need to save me.
Right.
Good
So
point.
it's a big place, right? I can't do it on my own. Neither of us can do it on our own. People like you, everyone in this room, has a role in the sort of the care of that patient. No, you're absolutely right. That's why I said we will stumble, but we'll ultimately prevail in the sense that there are teams that actually work very well, the TAVR team, but there are other opportunities like the PE team. There are other opportunities that when we work through our problems, that the other teams that are formed in the future will become much easier to sort of implement. But this is a big system, and big systems and trying to get the message out, communicating to critical care doctors, anesthesia. All these things take time, effort, and it's not going to happen overnight. We're going to stumble. That's why I always tell people, don't criticize, come with solutions first. Otherwise, the criticism is meaningless. The solutions are beneficial. We can build off that.
So guys, thank you again. And next month, the Paul Evans lecture, so please attend it. Thank you for a great presentation.